My name is Gail McGrath, and I'm a clinical nurse coordinator for children with life-limiting conditions, and we were previously known as children's outreach nurses for life-limiting conditions. There's a map there, and there are 10 of us dotted around the country. At the moment, I'm based out of Temple Street Hospital and cover North Dublin, and as Minister Harris said this morning, there is funding for a further role in 2018, which has been secured for Kerry. So the role of the clinical nurse coordinator for children with life-limiting conditions is to support children, families and healthcare professionals, promoting continuity of care, and we act as a link between hospital and the community, linking with the multidisciplinary team, and we hold regular interagency meetings with Jack and Jill and Laura Lynn, discussing current caseloads and planning for future possible needs. We also act as an informed resource and point of contact for parents and other professionals. We facilitate education and training in partnership with existing educational programs, and we collect data in relation to children with life-limiting conditions. And a previous review of the number of non-face-to-face contacts was conducted, and the number of contacts with professionals far outweighed the contacts with parents. It was approximately 3 times greater, which shows that need for communication and continued coordination and collaboration. So in terms of a referral to the clinical nurse coordinator for children with life-limiting conditions, it's when a child has an ACT life-limiting category and at least one of the following: an unpredictable or deteriorating health, which may include frequent unplanned hospital admissions, support with problematic symptoms, which would be in conjunction with support from specialist palliative care services, and significant disease progression, which may include resuscitation treatment agreements. Any healthcare professional can refer to our service, but ultimately the primary consultant must be comfortable that the child meets this criteria for referral, and also that the timing of the referral is suitable enough to make sure that a therapeutic relationship can be formed, but also that the main supports are focused on the latter stages of the child's illness. When a referral is made, we determine how soon the baby or child needs to be seen using our triage tool. We link with the referring team to see what current treatments are in place and what the future care plans are. We link in with other healthcare professionals who are currently involved or are to be involved in the future, and then we meet with the child and family and explain our role. And at the first ever Paediatric Palliative Care Conference, Claire Quinn gave a demonstration of the number of professionals that are involved in a child with a life-limiting conditions care. This was echoed in an evaluation last year of our service, and the need for coordination of care was again highlighted. So there are times when we take a step back, when the child is going through a period of relative well-being, and we are respectful of the parent's space, and also the need to link back in as the child's condition declines. So as was set out in our education and governance framework in 2012, the aim of the service was to add value to existing services so that children with life-limiting conditions could be cared for insofar as possible in the home setting. Through our work, we found that choice is of most importance to parents, and making sure that they have the information to make choices about location of care. And in terms of illustrating this, I'm going to discuss little Logan's story. When Logan was born, he had a cousin who was born 1 week previously, and at 23 weeks. And his mother describes great guilt at having an apparently well baby. That ex-23-weeker is now a 4-year-old who is happy and healthy, and Logan forms part of our story here today. So when Logan was born, he developed seizures soon after birth and was diagnosed at 1 month with early onset epileptic encephalopathy, ultimately being given a diagnosis of a neurodegenerative condition. He had a number of problematic symptoms that have been discussed already on case presentations today, with seizures, GI symptoms, but ultimately it was his respiratory compromise that was most problematic for him. He was linked in with Jack and Jill, who gave supportive care in the home, which increased in relation to his increasing needs. He was also linked in with Laura Lynn and with the hospice in Raheny. I was referred to him at 21 months, and at my first meeting with both parents, we discussed their preference for location of care at end of life, and both were very, very clear that home was the preferred location of care. At 2 years of age, little Logan had a respiratory arrest in hospital, and again at that time, we discussed the preferred location of care, and again, it was home. But ultimately, he had an admission to hospital at 3 years of age, with a lower respiratory tract infection, and it was clear that he was nearing the end of life. And at that time, the parents decided that they wanted to stay within the hospital setting. So it was reiterated the number of supports that were available to them in the community, but they were very keen to stay where they felt supported at that time. And I suppose the message to get across is that we can have children well supported and transferred home, but ultimately there is no right or wrong place for a child to have their end-of-life care. It's wherever the family feels is right for them at the time. And they were the words of the parents when I went to speak with them about sharing Logan's story, that it just simply felt right at the time to stay in the hospital. The interagency work continued within the hospital setting, with Jack and Jill offering nursing hour support and Laura Lynn providing memory-making activities. And I suppose the other message I want to get across is that death in a hospital isn't cold or of a lesser quality of a death than a death in a home. Professionals go above and beyond everything that they can within their own scope, between catering, providing meals for extended family members, visiting policies being waived, and everyone assisting the family as much as possible within their role, including in this case the IT department, who sourced 80s movies so the parents could watch the films that they liked when they were children, and shared the memory-making process with Logan as he was dying. Logan died surrounded by a loving extended family and twinkling fairy lights. And as I say, the parents would still report that it just felt right at the time, and they don't have any regrets that he died in the hospital setting and didn't go home. In terms of bereavement support, there was support offered from St. Francis Hospice, from Temple Street Hospital, from Laura Lynn and Jack and Jill, and different members of the family linked in with different aspects of each of those bereavement cares. So in terms of location of care, the first reference there is relatively old, but I think quite pertinent to this case, that home is thought of as where families sometimes want their child whilst living rather than where they want their child to die. Factors that impact on location of care have already been discussed by Kathy Gibbons this morning, and Terry spoke about the new discharge plan for end-of-life care, which it's hoped will be rolled out nationally. And in that, it includes 3 reasons why discharge may not be in the child's best interests. And that's if symptom management is extremely problematic, if it is likely that they will have a significant decline on transfer, or if that supports aren't sufficient in the home. But interestingly, the clinical nurse coordinators for life-limiting conditions submitted information to a study that was conducted by Tyrone Horn, and lack of home support was not recorded as a factor affecting parental choice regarding location of care. There is no single service that can meet the needs of a child with a life-limiting condition, and as was demonstrated already today, each add value to the child and family's care. Through the 4 different cases that were presented with different challenges in terms of location of care and patient and family requirements, most of which were overcome by a collaborative nursing approach. And in planning for this presentation, we spoke about a means of fostering continuous improvement and having meetings after a complex discharge. And my colleague Alison Cashel has a poster on display here today about after-action reflections, which is a process that we've already commenced in terms of continuing to evolve services to address challenges and aiming for a seamless service for children and their families. So in conclusion, as professionals, the difference that we can make is not in the outcome, but in the process of how the child and family live, often for many years, how the child dies, and how the family continue to live. And that's just a nice little Minions cartoon to show that coming together is the beginning, staying together is progress, and working together is success.